patient is Mr. Robert Smith, 43-year-old male that comes into the clinic with a chief complaint of, I'm not feeling really good, I feel lousy lately, and I have no energy and my stomach hurts. History of present illness, Mr. Smith has been complaining of bloody stool in his a bloody stool for the past few days and complains of moderate abdominal pain, which he rates a 6 out of 10. His review of symptoms, vital signs 99.5, low-grade temperature 120/80, blood pressure and heart rate 115, and respirations 22. Patient is well groomed and obviously in no distress at the time of my exam. Skin is cool to the touch and no normal turgor and no jaundice noted. HEENT, pupils round, reactive to light, moist mucous membranes, and neck is supple. Lungs are clear with auscultation bilaterally. Please breathe in deep. Exhale. Cardiac rhythm is regular with no gallops or murmurs heard. Okay. An abdominal inspection of the abdomen, no noted scars, distension, or surgical scars. Active bowel sounds noted in all 4 quadrants. And he's complaining of discomfort and slight tenderness with palpation of the exam. So he is neurologically alert and oriented ×3. And he's been complaining of irregular bowel movements with bloody stool for the past week, often experiencing these cramping discomforts after eating. And he wanted to come in and see what could be the possible reasons why. While gathering information, I also wanted to ask the patient about the pain. Where is it located? Does the patient feel it before or after eating? What's the quality of the pain that he's experiencing? Is it dull, sharp, stabbing, cramping? Is it aggravated? Or what makes the pain aggravated, or what makes it alleviate? And what does he think might be causing his discomfort? As I obtain the physical history from the physical assessment, I will obtain some diagnostic testing and a plan of care of treatment for the patient. He has a past medical history of chronic allergies and hypertension and diabetes, and has never had any surgical history. Socially, he's married with 2 children. He's a Walmart supervisor, and he walks 2 to 3 times a week. He drinks occasionally, and he denies any illicit drug use. Medications, Mr. Smith is on lisinopril, 10 milligrams, and metformin, 1,000 milligrams, and Lantus, 10 units Q every evening. I want to include in my subjective history any questions related to any changes in appetite, digestion, or presence of blood in any emesis, vomiting, or bowel movement changes, whether they're the frequency, regularity, and color of his stools, and any noted blood or rectal bleeding. Based on the examination findings, I conclude that the patient needs further diagnostic labs and testing. To do the abdominal exam, I will do imaginary section of the abdomen into 4 quadrants and listen for bowel sounds. So first, upon examining the abdomen, I'm going to inspect the abdomen for any scars or distension, ascites, any discoloration, bruising, and any fluid or masses that I can see on inspection. Once I do that, then I go to auscultation And what I'm trying to hear is bowel sounds in all 4 quadrants. After that, I do a percussion, so I'm trying to hear if there's any fluid or any dull pitches in the abdomen, noting any obstruction or fluid-filled ileuses. If there's air-filled intestines, it sounds like a drum or tympanic. And also watch the patient's visual expressions as you're doing the auscultation and palpation, percussion. Fourth is the palpation, which is last, and you will check for any guarding or a distension or any pain noted with the examination. So when I palpate, I want to do a light palpation on all 4 quadrants and check and see if there's any discomfort, and have the patient explain or express what he's feeling when I do the palpation. Then I'll do a deep palpation to check for any tenderness by the liver or the spleen, the appendix down in the lower left quadrant, or any possible torsion of the testes, and any sensitivity over the pubic, maybe a bladder infection, or around the kidneys. I would do a palpation of the kidneys. Deep palpation of the abdomen to assess organs and note if there's any rebound tenderness or abdominal masses, and none are detected. In the left lower quadrant, you would assess for the medial lateral mid-clavicular border to palpate the liver to see if there's any tenderness upon palpation, and if there is, what the patient is instructed to inhale if there is a positive Murphy sign that there is a inflammation of the liver. When you're checking the spleen, over on the left side of the patient's costal margin under the rib cage, if it's enlarged with palpation, the patient should be lying on the right side, and you can lift the flank and palpate by the kidney to see if there's any inflammation of the spleen, and that would indicate any gastritis or spleen infection of the spleen. Percussion of the kidneys would be on the back, checking for any abnormalities, redness, tenderness, heat, or pain with palpation to check and see if there's any maybe kidney stones or kidney infection. So upon completing the abdominal exam, I would recommend diagnostic testing with the ultrasound. Also, maybe a rectal exam to check for any hemorrhoids or active bleeding, any masses or any abnormalities of the anus. Do a occult stool sample for diagnosing of active bleeding in the lower bowel. Get a urinalysis for checking for infection of the kidneys. Do amylase and lipase lab tests to check for indication of infection or inflammation of the pancreas. And also I would recommend liver enzymes to check if there's any inflammation or indications of issues with the liver. A CBC panel to determine if there's any infection in the entire body that could be somewhere in the gastric area. Also recommend endoscopy or colonoscopy with a GI specialist to check and see if there's any ulcerations in the upper GI or the colonoscopy, any issues with the lower intestine that could be causing, finding any ulcerations or colitis in the lower intestine that could be indication for the cause of the bleeding that he's experiencing when he is going to the restroom. The plan of care for this patient is a diagnosis of acute abdominal pain related to irritable bowel syndrome with rectal bleeding secondary to hemorrhoids. So care plan for this patient, I recommend a review of a diet summary or diary, which will include increased PO fluids, a high fiber diet, and also education on foods to avoid, high food, fatty foods, or decrease in alcohol intake, and caffeine. Encourage the patient to increase his rest and sleep and exercise regime to better help his body to heal and to feel better. Educate the patient on symptoms of irritable bowel syndrome and have the patient verbalize symptoms of early IBS. Patient will demonstrate non-pharmacological techniques to help reduce pain during IBS attacks, as in examples of relaxation techniques, deep breathing, distraction, massage, and maybe some warm heat to the lower abdomen when he has these symptoms. Over-the-counter hemorrhoid cream is recommended for comfort, and follow up with a gastrointestinal specialist and a dietitian for continued diagnostic testing. Instruct the patient to avoid spicy, fatty foods that may cause the symptoms to exacerbate, and possible medication order for antispasmodics to help relax the muscles of the lower intestine, and antidiarrheal drugs, and a recommendation of probiotics to help with his digestive tract. Follow up with the patient in 2 to 4 weeks if the symptoms escalate or he's experiencing increased bleeding or the pain is increasing. Recommend that Mr. Smith return to the emergency room for further evaluation and possible hospitalization of his treatment. Thank you. That completes my assessment of the abdomen for Mr. Smith and my recommendations for treatment. Thank you.